We're starting the session on vitreoretinal diseases, problems and solutions. If any of co-chairperson, convener are in the audience, please join us. The first speaker is Dr. Rahul Prasad. He will speak on a review of hypertensive retinopathy and chorioretinopathy.
Thank you, sir. And a very good morning. At the onset, I would like to thank AIOS Scientific Committee for giving me this opportunity to present my topic. So just to recapitulate, hypertensive retinopathy is a condition characterized by spectrum of retinal signs in people with elevated blood pressure. It was first described by Marcus Gunn in the 19th century. A lot of things have been reviewed and understood much better in the recent times. Now, basically, there are three main causes due to hypertension that occurs in our eye. First is the retinopathy, second is the neuropathy, and the third is the chorioretinopathy. Hypertension is also the major cause of branch retinal vein occlusion, central retinal artery occlusion, retinal vein occlusion, and central retinal vein occlusion. Coming to the epidemiology, hypertension is a worldwide problem that affects almost 1 billion people worldwide and its single most important modifiable risk for stroke. It's more common in African Americans and the Chinese descent. The incidence, if we see, in less than 45 years, it's usually the men who are more involved, and greater than 65-year-old, it's women who are more prone to develop hypertension. Now, etiology of hypertension can be briefly summarized into three parts: primary hypertension, essential hypertension, and secondary hypertension, which occurs due to secondary diseases. The risk factors include obesity, ethnic, stress, family history, alcohol, and tobacco use. Now, the major risk of atherosclerotic hypertensive retinopathy is the duration of the elevated blood pressure. And the major risk for malignant hypertension is the degree of blood pressure over normal, and the genetic influence does have a very positive role. Now, it's necessity of identification and documentation of hypertensive retinopathy because it is an indicator of systemic morbidity and mortality. Mild hypertensive retinopathy signs such as generalized and focal retinal arterial narrowing, arteriovenous necking are weakly associated with systemic vascular disease, whereas the moderate hypertensive retinopathy signs such as isolated microaneurysm, hemorrhages, cotton wool spot are strongly associated with subclinical cerebrovascular diseases, which predict incident clinical stroke, congestive heart failure, and cardiovascular mortality. So, hypertensive retinopathy basically is the result of hypertensive retinopathy is basically due to two causes. First is the vasospasm, which occurs due to acute effect of the systemic arterial hypertension. And second is atherosclerosis, which is actually the chronic effect of hypertension. Just a couple of points about the pathophysiology. It is the chronic hypertension that leads to atherosclerosis, and the atherosclerosis predominance, which leads to narrowing of retinal arteriole, that leads to ischemia, hypoxia, increased capillary permeability, and that leads to focal retinal edema, hemorrhages, cotton wool spot, and the heart exudates. There are different phases of hypertensive retinopathy. The main phases are vasoconstrictive, sclerotic, and the exudative phase. In the vasoconstrictive phase, there is an elevated luminal pressure that leads to a local autoregulatory mechanism, which causes retinal arterial narrowing and vasospasm due to increased vasomotor tone, consequent narrowing of the retinal arteries, and the reduced blood flow. It is the initial response to the hypertension. The clinical finding includes generalized vasoconstriction. Only a particular vessel can undergo constriction, which is called focal vasospasm and focal vasoconstriction. In the sclerotic phase, due to persistently elevated blood pressure, there is layer of endothelial wall that undergoes changes such as intimal thickening, medial hyperplasia, and hyaline degradation that leads to worsening of the arterial narrowing. The clinical findings include the diffuse and the focal retinal arterial narrowing, arterial wall opacification, which leads to silver and the copper wiring, compression of the venules by structure changes in the arteriole, which is also known as the AV nicking or nipping. The arteriovenous signs includes the Gunn sign, which is the tapering of the veins, the Bonnet sign, that is the dilatation of the veins distal to the AV crossing, and the Sallows sign, that is deflection of the vein. So you can see the salut sign, the deflection in the first picture. The second sign is the gun sign, where we have got the tapering of the vein. And third is the bonnet sign, which is the banking of the vein distal to the AV crossing. Then we have got the exudative phase, which is occurred due to the chronically sustained blood pressure elevation in the blood retinal barrier is disrupted. The pathological findings include necrosis of the smooth muscles and endothelial cell, exudation of the blood and the lipid, and the retinal nerve fiber ischemia. So the clinical finding includes microaneurysm, retinal hemorrhages, cotton wool sword, and hard exudate. Then we have got the malignant hypertension that can cause papilledema, which is a result of both leakage and ischemia to the arterioles. Then we have the hypertensive choroidopathy, which is rare but can occur as a result of acute hypertensive crisis, which is also known as accelerated hypertension, where there is a sudden increase of the blood pressure above 180 by 110 millimeter of mercury in young adult, leading to sudden ischemia of the choroid. And these have effect on the retinal RPE cells in the retina. So we have got fibrinoid necrosis occurring on the choroidal vessels at the level of the choroidal capillaries, poor segmental infarction of the choroid, and that leads to poor perfusion. Signs of hypertensive choroidopathy include Essen's pearls, Steger streaks, pigment epithelial detachment, and exudative retinal detachment. This is an example of the Essen's spots. These are cigar streaks, detachment, and the optic neuropathy. Then we have got the optic neuropathy. A very important part of hypertension is also seen in pregnancy, which is eclampsia of pregnancy. So symptoms include eye pain, headache, and reduced visual acuity. So clinical diagnosis, there are different classifications given. Among the most commonly used is the Keith-Wigner classification. The recently Wong and Mitchell classification does have got advantages, and very recently optical coherence-based tomography uses subretinal fluid as a marker for its classification. So recent advances does include the provisions of AI, which leads to better understanding of the vasculature. Management is primarily focused on reducing the blood pressure, and it is the timely evaluation and the management of reduced ocular and systemic damage. Thorough history is vital for proper and timely treatment. Complication does include the central retinal vein occlusion, branch retinal vein occlusion, and microaneurysms. So prognosis is with severe hypertension, retinopathy, and atherosclerotic changes are at risk of coronary disease. Mortality of the patient with untreated malignant hypertension was 50 in 2 months and 90 in 1 year. So important is to diagnose and treat hypertension as soon as possible. Thank you.
Thank you, Dr. Prasad, for a comprehensive paper on hypertension. Thank you.
Thank you, sir.
Any questions? Thank you. Is Dr. Priyadarshini Mishra here? Dr. Priyadarshini will speak on double trouble, proliferative retinopathy in diabetic patients with chronic myeloid leukemia. Please
Good
start.
morning, sir, and good morning, all. My topic is double trouble proliferative retinopathy in diabetic patients with chronic myeloid leukemia. I have no financial interest in this presentation. Little background knowledge: chronic myelogenous leukemia is a myeloproliferative neoplasm affecting both peripheral and blood and bone marrow. Natural history: usually it follows a triphasic course, where a chronic phase followed by accelerated phase and invariably progression to a final fatal blastic phase with a variable period of time. And ophthalmic involvement: either one is primary direct infiltration that can mimic uveitis like vitritis, choroiditis, retinitis, occlusive vasculitis, optic nerve infiltration, and also infiltration of other cranial nerves and as well as orbit. And there is a secondary indirect effect which manifests due to hematological abnormality of the parameters, including anemia, and that manifests in hemorrhages and Roth spot Retinal manifestation can occur before systemic manifestation also. So the importance of ophthalmology is to diagnose this condition is very important. This is a normal CML case picture as I have shown and showing the hemorrhages distributed well up to the periphery. Whenever the CML coexists with proliferative diabetic retinopathy, although the pathomechanisms may be little different, but there is considerable overlap between the two conditions. In CML, anemia, leukocytosis, hyperviscosity syndrome, leukoembolization, angiogenic factors released, these all lead to the clinical manifestations, and the diabetic PDR also we get some of these manifestations, and this interplay between these two clinical entity and unveiling this interplay is a clinical task, a challenging task for us clinicians. So, diagnosis of in a diabetic patient continuing treatment for proliferative diabetic retinopathy, sometimes we need to be carefully look the clinical signs so that we will not miss the CML, coexistent CML. I will show some picture of some cases where these are the diabetic patients and in the course of their treatment, they are detected as CML. So, usually it is told that posterior pole, it is spreads far across the periphery one. We should carefully look forward the rod spots and other signs of CML. And Priya Vivi et al, they have used a terminology that is a string of bead sign. I also show in my pictures also. In fluorescent angiography, we can notice this sign string of beads. Usually in diabetic we don't find. It is usually signs of hyperviscosity. In some CRAO and resolving CRBO, you can find these clinical pictures. So diagnosis is very important. This is a picture of CML patients. As we can see, CF and neovascularization in periphery in the left picture. And in right picture, there is already proliferative stage patient presented to us with NVD and all fibrovascular changes. So now I am going to present some of my cases and where we stuck or where we get trouble treating these patients. This is a 44-year male, only 2-year history of diabetes. He came for routine checkup, but with the fundus finding, some doubt aroused. As you can see this picture, we can notice some vasculitis signs. Typically vasculitis like picture, carefully noticing some rod spot can be elicited. So we did an intensive workup. Besides diabetic, we also look for other causes of vasculitis as well as normal peripheral. CBC is a very low cost test that can be ordered in every diabetic patient. And we found that there is a high leukocyte count, white blood cell count, and on cytogenesis study, this is the angiography picture. As we can see, this is extensive ischemia in all quadrant. Luckily, the macula area is a little bit spared, but extensive CNP area along with neovascularization in other areas. So, cytogenetic study, it is confirmed that it is a CML case, and measure signs with all this, and this is the OCT picture with macular edema. So now where we went to trouble this macular edema was so intractable. This patient was very compliant. We kept on giving anti-VEGF regular interval and macular edema was responding definitely, but again it was coming and coming and coming. So like 12, 13, 14 injections. Initially, also by the advice of hematologist, hydroxyurea used, which usually act as rapid cytoreduction. Hydroxyurea along with allopurinol to combat the side effects, and then when the blood counts little bit stabilized, imatinib started along with oral anti-hypoglycemic. In the meantime, we ocular treatment continued and we did also pan-retinal photocoagulation. But despite this aggressive treatment and patient finally regular anti-VEGF, patient vitreous hemorrhage result. That is not the only problem. After surgery also repeat hemorrhage occurred. So again vitreous lavage was required in this patient. So this is another patient, this is the follow-up period. You can see we feel that okay this condition is fine, but no, in long-term follow-up ultimately they lead to some end up in surgery. This is also another case, same intractable macular edema, multiple injections we required and dexamethasone implant also. So these are all cases despite good PRP laser and multiple injections. This is our case also, same. So what we problems encountered, I am talking, this is one problem that resistant macular edema. So obviously I will need the opinion of our expert present here, and frequent need of surgery despite aggressive treatment, and also we should consider the drug related factor, that is imatinib. Periorbital edema most common, but already some hemorrhage, retinal hemorrhage, vitreous hemorrhage also has been documented. So subretinal fluid, cystoid macular edema. So whenever possible, we will consult our oncologist to change the medications. The newer like dasatinib, nilotinib, and dasatinib also not documented, much literature not available, but optic neuropathy, one case I found. And so these newer drugs we can switch if we feel that macular edema is not resistant. And so very aggressive approach is required in this patient, and we should be careful to timely pick this diagnosis, because we are thinking of we are treating diabetic retinopathy and we are getting another disease. So some points need to be discussed, or some that screening guidelines, should we alter the screening guidelines? How aggressive and which treatment? Like in optic neuropathy, we have already methotrexate and rituximab we are using. I have not used this drug for this retina conditions, but should we switch to those drugs? And third is early switch to other anti-VEGF or steroid. If anybody has any experience in using this drug, because dexamethasone implant, I have also switched to dexa implant. And what precautions should we take during surgery? This is also a doubt. Why all these patients develop recurrent bleeding, and again vitreous lavage was required for these patients. So thank you all of you for the kind listening. Thank you.
Any comments from the audience?
I have experience with one patient who I was treating for non-proliferative diabetic retinopathy for several years with DME. So he was quite mild disease, but he started imatinib for his CML or AML, and suddenly he progressed to neovascular glaucoma in one eye. He just came with pressures of 60 plus, severely painful eye, and the other eye also started developing vitreous hemorrhage. So when I read up, not only for this case but for other cases as well, we have seen that these newer tyrosine kinase inhibitors, TKIs, they have so many ocular adverse effects that they can have any adverse effect from the cornea to the retina, and in the retina anything, vitreous hemorrhages especially, recurrent vitreous hemorrhages without any neovascularization, recurrent CME or almost anything. So this patient, we finally managed to treat the neovascular glaucoma and the hemorrhages, but what I'm saying is that our vigilance should go up once they are on these TKIs. And any patient who comes with unexplained vitreous hemorrhages, we should look into their history of medication, and if they are on TKIs, we should request change of the TKI.
I also had an experience of patient with a CML NPDR with a branch vein occlusion, presented with vitreous hemorrhage in one eye, NPDR in the other eye. And in case, so one eye got vitrectomized, was treated with hydroxyurea of almost about 15 years back. And the patient responded pretty well. So it's important to treat the baseline disease, and after that we made it a point that every patient in diabetics, if we find any vasculitis, we make sure we investigate it completely. Every patient we get a hemogram done, and we look at the leukocyte count, because that is very important.
That should be how routinely included.
Thank you, Dr. Arora.
Thank you, sir.
Thank you. Dr. Tinku Bali here. Dr. Malika. You talk next. Dr. Malika Goel will speak on Dr. Malika Goyal will speak on management of retinal vein occlusions.
फोटो मत मारना मेरे ऊपर. हाँ, फ्लैश नहीं करें. बंद कर दो प्लीज. So good morning everyone. I'll be speaking on our experience with retinal vein occlusions. So the most important risk factors when you see a patient is not just to treat the eye, but first investigate and look for these factors which need to be addressed. Hypertension, diabetes, dyslipidemia, tobacco use. And in younger patients, more commonly is inflammation, which may be idiopathic or secondary to some of the diseases, homocystinemia, some malignancies, thrombophilia, and medication use, oral contraceptives, and sildenafil. So unless we look for these, we are doing great injustice to the patient because the actual problem is not solved. And in the eye, we need to be very vigilant about glaucoma in these patients because it's a very common comorbidity. And it may be responsible for the RVO in many cases. So look at the disc very carefully. It is easy to miss an early glaucomatous change or a notch. And once glaucoma is confirmed, avoid steroid injections for the macular edema because it can increase the IOP. And to treat the glaucoma, avoid drugs which can increase the macular edema being caused by RVO. Also, I have found in my work that severe papilledema can cause vein occlusions by compressing the vein from outside, apart from the internal occlusion which happens from the diabetes and hypertension. Papilledema compresses it from outside, adding to the problem. So RVO can be classified based on the location of the occlusion as central, hemiretinal, superior or inferior, and branch retinal, which can be one of the four. And these can be ischemic or non-ischemic, as well as the branch vein can be a major vein or a macular branch vein. Now, ischemic CRVO and HRVO are the worst in terms of prognosis. There is a drastic vision loss, extensive hemorrhages, and the vision remains poor even after the macular edema has resolved with injections because of the ischemia. The edema may not even be severe, but still the vision is not good due to the macular ischemia and requires extreme vigilance for neovascularization of the iris. Hemiretinal vein occlusions, only 2 quadrants being involved, still requires vigilance because relatively larger extent of involvement. So as I mentioned, extreme vigilance for iris new vessels. The highest risk used to be in the first 3 to 6 months earlier, but now the risk comes when anti-VEGF injections are stopped for the macular edema. So that could be even a year or 2 after the onset of disease. And non-ischemic cases are also not safe because they can progress to ischemic type in the natural history. So every case of CRVO and HRVO has to be counseled about reporting early symptoms of pain, redness, IOP rise. Non-ischemics have a better visual prognosis, respond with better visual acuity, fewer injections. Branch vein occlusion, the fundus can rapidly start looking normal, but there would be recurrent CME. The way to make a diagnosis might be looking at collaterals or the OCT angio, which shows capillary non-perfusion in the superficial and deep capillary plexus. Chronic CME can lead to epimacular membranes in the BRVO, macular hemorrhages, and over time, BRVO is also not harmless. It can present with vitreous hemorrhage, neovascularization of the disc, and these are asymptomatic cases. So they need annual review to be able to pick up proliferative retinopathy. Look carefully at the disc, very easy to miss neovascularization on the disc, and if this is seen, we can start the sector scatter laser. As in these patients, they are asymptomatic with minor vitreous hemorrhages. So annual review is extremely important. Even with this is a vitreous hemorrhage where there is BRVO with the macular ischemia and new vessels. Macular branch vein occlusion at least does not have a risk of proliferative retinopathy, though it can have resistant macular edema, which is recurrent, and continues to show ischemia on the OCT with a hyperreflectivity of the inner retinal layers. It can also present with hard exudates if it's a chronically untreated macular branch vein occlusion. And the fundus picture can look completely normal in a macular vein occlusion very rapidly, but it can still get CME. So the best way to compare know whether it's a RVO is to compare the vessels with the other eye, where you can catch the minor tortuosity compared to fellow eye. You can see the collaterals, which may be very subtle, but OCT angio is very important to make the diagnosis. Fundus photography is very important even in the OCT era because it can pick up hard exudates which cannot be picked up by OCT. OCT can show, apart from edema, vitreoretinal interface changes, foveal thinning as a sign of prognosis, and external retinal layers disruption. OCT angio can show non-perfusion, new vessels, but fluorescein is mandatory to identify macular leakage for macular laser. This is to show how a photograph can show us hard exudates which are resolving even when there is no CME. But we still treat to prevent the hard exudates from coming into the foveal center. Again, a patient with exudates which have increased because of 1 year of no treatment, no injections. And then as soon as we start injections, within 2 months, you can see the hard exudates have significantly resolved. So photographs are also very important, not just OCT. This is again a patient that was treated with 2 injections over 3 years. Now the OCT would show that there is no change, but the photograph shows that the exudates have resolved. So we have prevented exudates from coming into the foveal center. OCT, even if the edema goes away, the OCT continues to show the ischemia as hyperreflective area. OCT angio is very important to show collaterals, capillary dropouts, even neovascularization of the disc. I use it most commonly when there is a suspicion of NVD. And sometimes you can see an florid NVD on octa, which is not very clear on examination. FFA shows the leakage, which can be used to target the laser. And fluorescein also sometimes is useful in hazy media, as in asteroid or vitreous hemorrhage, where octa is not useful to show the neovascularization on the retina or disc. It can also pick up sometimes new vessels on the iris as a massive leak which was not otherwise detected on clinical exam. Treatment, of course, remains serial anti-VEGF injections. Laser or intravitreal steroids or vitrectomy remain only secondary options. There is a dramatic improvement with anti-VEGF injections, and this is the whole list available. Steroids can be triamcinolone or dexamethasone implant. But steroids continue to have side effects, so remain treatment of second choice after anti-VEGFs. So when to consider steroids? Only when anti-VEGF is contraindicated, as in pregnancy, cardiovascular events which are recent, severe renal dysfunction, or where traction may worsen with anti-VEGF. Do I have 1 more minute? So laser for BRVO has been shown to be useful, but now we use it only where patients continue to get several recurrences on injections. But we don't use it for every patient of BRVO, only when there are recurrences of macular edema. And this is a patient where patient did not want injection, and you can see that just laser has stabilized the patient with good 6/6 vision. Over 1.5 years, there is no injection given. However, for CRVO, there is no benefit to macular laser for macular edema. Every patient of RVO needs 6 to 12 monthly checkups, even if vision is good, for new vessels on the iris and on the fundus. And for more importantly, for fellow eye involvement, which is often very silent. You can see these are cases of bilateral RVO, and the fellow eye was silent. Lastly, CRVO can often come with celoretinal artery occlusion, so suspect this when vision is disproportionately poor to the macular edema. OCT angio can show, as you see in the picture, non-perfusion to confirm the celoretinal artery occlusion, and vision doesn't improve despite macular edema resolution with the anti-VEGF injection. And lastly, in the young, inflammation is usually the cause, which is mostly idiopathic, and the prognosis remains good. Many of them do not need an injection even, or a single injection generally suffices without requirement for repeat injections. Thank you.
Thank you, Dr. Malika Goyal, for elaborate discussion on venous occlusions. Any questions, please? Dr. Ajay Arora.
So, Malika, excellent talk. What I've seen is in some cases of BRVO, which is very mild, you don't get any change on octa in the superficial plexus, but you do have ischemia in the deep capillary plexus. So, I just wanted to, as a take home, that we must look at the DCP in these cases than only looking at SCP, because unfortunately in most of the machines you cannot measure FAZ in the DCP, you can only measure in the FA or in the superficial capillary plexus, but you can extrapolate by looking at serial images, and that tells us how this case is progressing. Another observation which I just wanted to say, you have mentioned about IVT and Ozurdex. We have been using supracollateral steroids in these cases. So by using supracollateral steroids, you are actually removing the complications which steroids cause in these cases, and yet get the same effect. So these cases are doing pretty well in our hands, and is working well.
Yeah, and cost efficacy would be great.
Cost efficacy, it's a complication
Yes.
of glaucoma or complications of cataract produced by steroids in these cases.
Yes.
Malika, excellent photographs. Two comments and two questions actually. Comments were that there's no doubt that invasive FA in asteroid is better than non-invasive octa, and laser for BRVO is a very good option. Questions were that treatment of a patient of RVO with hard exudates without macular edema for what?
Yes,
Because,
sir.
and treat with what?
Treat
Because if
with
there is
what?
no macular edema, still you want to treat hard exudates,
So
apart
the-
from control of metabolic profile and those things.
Yeah, thank you, sir. Regarding the query about hard exudates, even if there is no macular edema, if the exudates you feel they are coming very close to the macular center, then I think it's better to prevent with a couple of injections and then take care of the lipid profile of the patient, hypertension, diabetes, of course. That is the only long-term management. But we need to get them out of the foveal center, because once they come there, later on when we inject, the exudate will go away, but the vision never returns to
No,
normal.
I agree. We do not want hard exudate to come
Yes.
to the center. But treat with what?
Treat with what? Okay. So I treat only with anti-VEGFs, sir. These newer anti-VEGFs, they are good enough. You don't need intravitreal steroids for that. There's no benefit, and in fact, we know the side effects. Most of these patients are phakic, so we don't want to create a problem. And IOP rise also, again, now we need to keep chasing the patient for IOP checks. So even if you say that it may last longer, which I don't think so, because with the newer
No,
anti-VEGFs, they last.
my doubt is that should we or should we not treat these patients? Because the thing is, aim is very good that we don't want hard exudate to come to center. But methodology of interval injection, that because we know these injections, whatever you may do, the migration is prevented primarily because of edema only. If there is a edema, you resolve it, hard exudate may go into center. But if there is no edema, then also you inject interval anti-VEGF.
Sir, I actually have patients, because of time I have not put many slides, especially DME, where also RVO, where there is no edema, but the hard exudates have progressed very badly. The fundus looks terrible over months because the patient refused injections. And so even without macular edema, they do not seem to follow the same course. We have patients where edema resolves but hard exudates increase. On the other hand, hard exudates resolve but edema continues to come back. So they do not seem to follow so hard exudates can worsen even without edema, it seems.
Thank you.
Thank you, sir.
Thank you, Dr. Malika Goyal, Dr. Ajay and Lalit Verma. So Dr. Lalit Verma has the next talk. He'll be talking about on vitrectomy in PCV.
Thank you, sir, and thanks to the organizers of this third midterm AIOS and LOC for this wonderful arrangements. I'll be talking about an entity which is assuming more importance because of recognition, because PCV is a fairly common diagnosis in Asia. And one of the issues with PCV is submacular hemorrhage. Submacular hemorrhage can occur in a lot of other conditions like ARMD, macronism, trauma, but PCV is one thing which I'll be talking about now. So at the outset, macular hemorrhage for a general ophthalmologist needs to be differentiated whether it's a subhyaloid or a subretinal. Because in contrast to subhyaloid, the subretinal is an emergency, is one of the ophthalmic emergencies. We can't leave this patient. Whereas subhyaloid, you can easily watch or do or laser or maybe surgery also. And the natural course of subretinal hemorrhage generally poor because of multiple factors, toxicity of iron and clot retraction and even a mechanical barrier also. But if it is subfoveal, it causes profound visual loss because of the same reasons of, and that is the reason we want to treat it on a war footing. We can't leave it because of, irreversible damage to the retinal photoreceptors. Remember, this blood is amongst the rods and cones. And what happens if the blood is amongst the rods and cones? If it retracts, the rods and cones may be destroyed also. So I'll describing a couple of scenarios of this. This is what I call a mild kind of subretinal hemorrhage, although it is involving fovea. You do the imaging technique, and we gave only interval anti-VEGF injection only, and patient responds reasonably good. So this is the pre and post-op fundus picture as well as the OCTs of the same. This is another patient who had a relatively smaller submacular hemorrhage, vision down to 636, and OCT shows classical subretinal hemorrhage. And you give one injection and another two injections, patient becomes reasonably good, macular hemorrhage resolves, OCT picture also improves, and vision also improves. Another example of same small submacular hemorrhage, you see OCT, there is a big RPED showing evidence of IPCV and a submacular hemorrhage with some fluid also. With one shot, patient has improved quite a bit, and ultimately patient gained 6/24 from 6/60 and good resolution on OCT also. Scenario number 2 is that you have a relatively bigger or larger subretinal hemorrhage, which may be thicker also. Some people measure thickness also. This, if you treat, to my experience, this patient does not generally respond to only injections. So do not waste time in giving only injections. So these patients, I insist on under topical anesthesia only, you do a pneumodisplacement. You inject C3F8 gas and also an anti-VEGF injection. And then position him prone for some time, and then you see this patient generally migrates because the blood gets shifted from the important area to an unimportant area. What was there in the central part, now it has shifted to an unimportant area. So that is what this pneumo does, that pneumo will displace this large subretinal hemorrhage to an unimportant area. And remember, this pneumo is not the treatment. Pneumo is just a mechanical displacement. We still want to keep giving Eylea or anti-VEGF for long time. But ultimately, you have to address the cause. So this was that presentation. Then we repeated angiography as well as ICG and found some area for laser, and this we definitely lasered this area. This was another patient, large subretinal hemorrhage in the left eye, right eye, old scarring here, PCV. So again, treat this on a war footing, and after pneumodisplacement and continued treatment with aflibercept, this patient did pretty good. And this was the serial OCTs. If you see from down to the top, this response is pretty good, and concavity of the foveal contour has come back. So pneumodisplacement is a cost-effective technique and works very nicely in moderate amount of subretinal hemorrhage. But remember again, pneumo is only a mechanical job. You have to keep treating the cause with anti-VEGF agents. The last scenario is when you have a massive subretinal hemorrhages. Things like these again will not respond only to anti-VEGF. They will also not respond to only pneumodisplacement. So for such you require a vitreous surgery. So this was a story of one elderly lady who came with sudden loss of vision 2 days back. So we counseled her that you have to be treated today. Today means you have to be done as early as possible. So ultimately she agreed, and next day we pushed her for surgery. This was the FA and ICG which we had done, revealed a polyp. Left eye was absolutely okay. So we planned this surgery, and so this is the vitrectomy which we did for this lady. And after the core vitrectomy, as usual, you can notice the huge amount of on the entire posterior pole. There is a large subretinal hemorrhage. You inject some triamcinolone crystals to get the posterior vitreous face completely detached and take it out. This is the IVTA being injected, and then the hyaloid is picked up. And after the hyaloid is picked up, then you have this dual needle where the tip is of 41 and and then you load this RTPA, recombinant plasminogen activator, inject generally at 2 or minimum 2 or 3 sites, because one site may not be enough because of the loculation of this blood. Because if you inject only one place, it may not respond as nicely. So there are 2 places I injected RTPA, and you see this was day 1 in fact. This was day 1. You see this has responded reasonably well. And after follow-up, I kept giving aflibercept repeatedly, even in this eye, even though the gas was still there, we kept giving this RTPA. And foveal contour started improving. This is the final picture of this. If you see this right eye, and this is the right eye of the last follow-up. Reasonably good response to vitrectomy plus RTPA plus aflibercept. This was another patient, a medical professional who presented with sudden loss of vision. This was the picture which you could take. And on the surgery, what we found was after doing a core vitrectomy, again same steps, you inject triamcinolone for getting this hyaloid out, and then you see massive mounds of this black colored virtually subretinal hemorrhage here. So these mounds again, we took RTPA, recombinant plasminogen activator, and injected at multiple settings, multiple points. So this was one point where I injected RTPA. There are various ways of injecting. One is a mechanical. There are automated systems also available where you can inject RTPA like this. And then once you have done this, there's no need of lasering these points because they are very too small, and posterior pole normally don't require lasering these points. And then you do a fluid gas exchange. So this was day 1. And then fortunately, because the macula was very good, this patient recovered 6/9 vision from PLPR only. This is pre and post. So thus to conclude, firstly, we should definitely distinguish. All macular hemorrhage are not same. Subretinal hemorrhage require treatment of wart-suturing. And what I believe is small subretinal hemorrhages will respond very nicely to only anti-VEGF. A moderate degree or slightly thinner hemorrhages require pneumodisplacement plus continued treatment with anti-VEGF. And a massive subretinal hemorrhage requires intervention with the vitrectomy plus subretinal TPA plus gas injection plus continued anti-VEGF treatment. Thank you very much for your patient listening.
Thank you, Dr. Lalit Verma, for extensive management options. Any questions? Dr. Malika.
So very good slides. What is the, do you use intravitreal TPA when you are giving intravitreal anti-VEGF?
Yeah, we used to use, in the second category, sometimes we used to use intravitreal TPA, but I did not find any difference between 2 groups. One was only gas and anti-VEGF, the second was gas plus intravitreal TPA plus injection.
Yeah, there's no definite studies to show the benefits. So each of us has to just see what we can find. Personally, I found some benefit. Even in the same patient, 2 eyes in one eye did not give, one eye gave, and there was a difference. But that may be coincidence. Do you look for sub-RPE hemorrhage on the OCT before you go for surgery? If it's sub-RPE, probably you would not operate.
Yes, correct. That I should have pointed out, but sub-RPE carries the worst kind of prognosis. There you cannot, because you can't puncture the RPE and get the blood out of it. These patients do not respond. Sometimes I've seen sub-RPE may get displaced by gas only, may get displaced, but generally not. Generally prognosis is worse in such cases. And you're right that pre-op OCT, both these patients I could not do because of the vitreous hemorrhage already being there. But I have pictures where if the media is clear, you should get some information on OCT, whether it is subretinal or sub-RPE.
Yeah. And,
or sometimes sub-ILM also.
Yes.
Yeah.
Then again, that's not harmful, harmful.
Yeah, sub-ILM is not harmful at all. My basic aim of presentation was to recognize this as an ocular emergency and treat it on a war footing.
That's true. And most of the time, even if media is clear, it's before going for surgery or even pneumodisplacement, it's better to do a B scan Because afterwards there may be a breakthrough hemorrhage and you're not able to do OCT to see how the macula is behaving. But if you have a pre-op B scan, you can compare the resolution with the B scan. I've had that problem.
Correct.
Especially with massive hemorrhages. They come into the vitreous.
Correct.
And sometimes the fluid, the heme may not be maximum at the foveal center, but just above it or below it. Now if we do a prone positioning, we bring most of the blood into the center. So
In any case, if it is that, I may not go inside. I may not go inside. Because if the media is clear, there is no vitreous hemorrhage, but there is a heme, say nasally, massive heme also, or sparing the fovea,
But
generally
you're
I
not
will
sparing the fovea, it is in the fovea, you want to salvage the fovea also, then you would probably during surgery remove the blood rather than leave it in with TPA gas. You would actually put TPA, allow it to liquefy and then take it out so that your foveal center is spared.
The only issue with such, I have done it, but requires multiple retinotomies. It does not come away with one retinotomy. Does not. Yes.
Thank you, sir. Thank you very much.
Can you? You see, this could be a suprachoroidal kind of blood. Maybe you can drain externally sometimes. Sometimes you can drain externally these hemorrhages. But going in a phakic eye, if it is just behind the lens, it is actually very risky, or you may have to sacrifice the lens. You can try doing external drainage in such patients. And maybe along with some AC maintainer, or so that you have to have internal pressure which has to be raised, then only this blood may come out. Or that is the only way. But suprachoroidal, we have definitely drained like this, even with trocar cannula if you insert, and the other trocar cannula to raise the pressure. This just comes out with a routine trocar cannula also. If it is subretinal, it is difficult. Subretinal, it is actually difficult. Anybody has any other, comment on this?
So very good cases, sir. So I had a couple of comments that there are studies which have shown that intravitreal versus subretinal TPA, there's not much difference being shown in the results. So they say that you don't really need to go subretinal, even injecting in the.
So you see, I agree with you. I also used to maintain that, but in very large subretinal hemorrhages, what I found is I did try intravitreal route. This generally does not help. My results with intravitreal TPA versus without intravitreal TPA with pneumo procedure were equally the same. Pneumo did the same job as intravitreal TPA. So therefore, I showed these 2-3 videos where we have injected subretinal, and there is a so-called guaranteed benefit. It will come. It will come. Whereas intravitreal, you still pray to God that it may come.
Some surgeons, they also use air. Do
Yes.
you use air, sir?
Yeah, I have not tried, but I know about this, and a lot of people say in the recent, meeting a couple of months back, I saw that they say low-cost solution is you forget about RTPA, you inject only air. That also may work. And people injected subretinal anti-VEGF also.
Anti-VEGF
also.
Yes. Last question. In these cases, if there's no view, like you showed some cases where there's vitreous hemorrhage, so often the predicament is that in that age group, sometimes you suspect a mass lesion, and it's very difficult to really conclusively say that whether, there's any mass lesion and, or if the fellow eye is fairly normal, are there any telltale signs to say that this is a subretinal hemorrhage and not a mass lesion in that age group, in about 80-85 years age group?
That is what I think Malika also says. A pre-op ultrasound may help you because of the characteristics of ultrasound. If you have measurement of angle kappa also and see the reflectivity behavior of the contents of the mass, then you can talk to the patient that this is a huge elevation here. This could turn out not to be hemorrhage and could be something else. Apart from a systemic workup and other pointers which may sometimes tell you, but you can be surprised during table also.
Yeah. And MRI doesn't help, sir, because they are unable to differentiate between. Yes.
Correct. Yeah.
Thank you, sir.
You see, I had one patient I did not show a huge elevation. Ultimately, we had to do a retinectomy to but take it out.
Dr. Ajay, only one question because we are running out of time.
The answer to what he asked was a bullous this thing, and as sir just suggested, I've done one case, and I think Manish presented a patient where he did a large relaxing retinotomy, reflected the retina, removed the blood.
Yeah, yeah.
and that was-
That's, you see, whenever you do retinectomy, large, believe me, long-term results are never good. It shows very nicely. Video shown is very good. But long-term, if you follow up for a couple of years, these patients don't do well. Therefore, I was telling that you can do an external this thing if possible, so as to only thing to maneuver your instruments inside the eye. That's all. But not as the main.
Another thing, just a suggestion, sir. I have a beautiful video where you were injecting with a 41 gauge needle or a 39 gauge needle. I just presented yesterday a device which is foot controlled, because whenever
Yes.
you inject subretinally, there are some hand movements. With that device, there is no hand movements. So you can inject it.
I did mention that you can do an automated thing.
Okay, thank you.
Yeah.
Thank you, Lalit. Is Dr. Saurabh Verma here? Ajay, Dr. Ajay Arora, next speaker on micro pulse.
I'm here, sir.
Saurabh Verma?
Yes, sir.
Okay, sorry.
Very warm good morning to all of
Dr.
you.
Saurabh Verma will be speaking on management of suprachoroidal hemorrhage. Please stick to the time because we are running very late.
Sure, sir. So very warm good morning to all of you. I'll be talking about management of suprachoroidal hemorrhage. It is collection of blood in the suprachoroidal space due to rupture of posterior ciliary arteries. It can practically happen after any ocular surgery, but it's most commonly reported after glaucoma surgery, and the incidence rate ranges from about 0.7 to 2% in different reports. It occurs due to high preoperative IOP, which drops suddenly and is a potentially vision-threatening complication. Major systemic risk factors include use of anticoagulation, advanced stage, atherosclerosis, ischemic heart diseases, respiratory diseases, etc. Major ocular risk factors include history of glaucoma, aphakia, pseudoexfoliation, presence of a choroidal hemangioma, previous ocular trauma or ocular surgery, use of mitomycin C during trabeculectomy. Intraoperative risk factor, most important, is prolonged or complicated eye surgery, especially complicated by vitreous loss. And postoperative risk factors include hypotony and Valsalva maneuvers. In order to prevent it, preoperatively, we have to lower the IOP, manage hypertension, and stop any anticoagulants or antiplatelets. During the surgery, again, we have to manage the patient's systemic parameters. In the post-operative period, it is essential to avoid all forms of trauma and avoid hypotony. In extreme cases, high-risk cases, you can also avoid analgesics with anticoagulant activities such as ibuprofen and diclofenac. Intraoperatively, when it happens, there are certain signs which can help you in identifying it, which include increased IOP, sudden shallowing of anterior chamber, change in the red reflex, and vitreous prolapse. So if it is suspected of happening intraoperatively, you have to promptly close the surgical wound site. You might have to cut the tissue, compromise iris and the vitreous tissue so as to achieve prompt closure. In very rare situations, if you cannot reposit any tissue, you can try and drain suprachoroidal hemorrhage then and there, then reposit the tissue and suture it, but it should generally be avoided, and suprachoroidal management should be left for a later date. When detected in post-operative period, patients present with intense pain, decreased vision, nausea, vomiting, and headache. Slit lamp examination will reveal a shallow AC. There might even be vitreous prolapse. Indirect ophthalmoscopic examination will reveal loss of red reflex with choroidal mounts. So ultrasonography plays a very, very important role in diagnosing as well as follow-up of these patients. You see these dome-shaped detachments with spikes in the suprachoroidal space. If there is high internal reflectivity in the suprachoroidal space, it is suggestive of clotted blood, which will be difficult to remove. If there is low internal reflectivity in the suprachoroidal space, it is suggestive of lysed blood, which will be relatively easier to remove. On follow-up, we have to assess the state of liquefaction and the height of CD. If the height is reducing and the liquefaction is increasing, you can probably simply observe such patients. But if the height is increasing, or if there is appositional choroidal detachment, aka kissing choroidals, then you have to surgically drain it. Of course, IOP and inflammation has to be managed medically. It is generally said that it takes about 7 to 14 days for the clots that have formed in the suprachoroidal space to lyse completely, and this is when you should ideally plan for a surgical intervention so as to achieve maximal drainage. But there are certain indications where you have to intervene early, which include a coexisting RRD, central retinal deposition, because it increases the risk of retinoretinal adhesions if it persists for more than 3 days, high intraocular pressure, and deteriorating vision. So there are basically two surgical approaches to manage it. One is a sclerotomy, and this is a video courtesy of Dr. Rohan Chawla. This was a patient who was referred to us after a phaco surgery, He had developed a positional suprachoroidal hemorrhage. We have secured an AC maintainer to achieve positive pressure during the intervention and done a localized peritomy inferotemporally. In this particular case, we have made a large sclerotomy, about 4 mm in size. And as soon as you enter in the suprachoroidal space, you can see a little bit of fluid starts egressing out of the sclerotomy, which is an indicator that yes, this is the end point of the sclerotomy. Then by using a cotton tip applicator, you can apply pressure over the globe, and the blood comes out very easily when you're using a large sclerotomy like this. In this particular case, we did an indirect ophthalmoscopic examination at the end of procedure and saw that there was a large nasal tear. So we did a combined VR surgery, and the patient's vision was 5/60 after about 3 months. This is another surgical video, and nowadays would generally recommend making a smaller sclerotomy. This is a 2 mm sclerotomy made about 8 mm behind the limbus. Of course, with smaller sclerotomies, you might have to do a little more manipulation. You might have to use additional instruments so as to keep the lips of the sclerotomies apart. The drainage might be slow, but usually sufficient drainage can be achieved by such small sclerotomies also. A modified technique that has come up recently is using a trocar cannula system inserted acutely into the suprachoroidal space. So here's a surgical video of the same. In this particular case, there was suprachoroidal hemorrhage post-trabeculectomy. Again, we have secured an AC maintainer to achieve positive pressure. A 23 gauge non-wall trocar cannula is being inserted into the suprachoroidal space, and you can see as soon as we took out the trocar, the blood starts egressing out through the cannula. You might have to do a little bit of manipulation that helps in removal of more blood, because sometimes, because the lumen of the cannula is small, even very small clots might occlude it. And you can see how well the glow has improved from what it was to begin with. These are the pictures of the same patient. So drainage can actually be done anywhere between 4 mm to 12 mm. That is the usual extent of suprachoroidal hemorrhage. We would usually now recommend draining somewhere around 8 mm. This is where the height of the choroidal detachment is maximum. So any iatrogenic damage to choroidal tissue or retinal tissue would be minimum. But yes, there are certain authorities which recommended draining at about 4 mm behind the limbus. If you have clots in the suprachoroidal space, then you are not left with any other option other than doing a sclerotomy. In this particular case, again, there was a positional suprachoroidal hemorrhage, but the blood was clotted. We made a small sclerotomy in the inferotemporal quadrant, and then by applying pressure over the globe, these clots were expressed out. Of course, you cannot remove all of the blood in such cases. The purpose is to remove blood which actually takes care of the oppositional status of the choroidal detachment. A lot of blood and clots might even be left at the end of the procedure. So suprachoroidal hemorrhage tends to have very, very poor outcomes, especially in the presence of a coexisting retinal detachment and a 360-degree suprachoroidal hemorrhage, where less than 10% patients actually achieve visual acuity greater than 20/200. To summarize, prevention is to be done by optimizing all parameters, both intraoperatively, postoperatively. Immediate wound closure is to be done in intraoperative suprachoroidal hemorrhage. Follow-up of the patients is done with serial ultrasonography to monitor liquefaction and height of CD. Ideal time of surgery, if you can wait for it, is about 7 to 14 days. Early drainage is warranted in certain conditions, which we have already discussed. And external drainage with trocar cannula system is a safe and easy method if the blood is sufficiently lysed. I would like to acknowledge all my seniors. These are not my ideas. These are my seniors' ideas, just my presentation. Thank you.
Thank you, Dr. Saurabh Verma, for a nice presentation. We will have no discussions because we are running late. Dr. Ajay Arora to speak next. Sorry, Ruchira. I thought you... There is a slight change in program. Dr. Ruchir Tiwari will be speaking on online speaking on re-imaging, drying and durability with Broluki Mujab. He's coming online. And I think Dr. Tinku Bali has also arrived. We'll speak later. There's no picture here.
Hello. Ruchir, can you hear? Dr. Dr. Ruchir? Is he online or not? Ruchir? नहीं ये तो डॉक्टर क्रोनोपोलिस डाल दिया रुचिर को लगाओ रुचिर is there now yeah Dr. Ruchir, can you start your presentation and share slides?
Is my presentation visible?
Not yet. Yeah, now it's okay. You can go ahead. Go ahead, please.
So I'll be talking about reimagining drying and durability with brolucizumab. So this is under disclaimer. There's no financial interest involved. So I shifted to brolucizumab in my practice in the very early days simply because of the durability of the drug. I started initially with difficult situation, non-compliant patients, non-responders. Then I switched to treatment-naive patients and for treatment optimization, and finally to non-CNV indication as well as DME. I'll be sharing some of my cases. So this is the first patient that I tried this drug on. I first saw the patient in September 2020, BCVA 6.9. Now this is a one-eyed patient. He came back to me in April of 21. His BCVA had gone down to finger counting close to face, and he had developed a very large RP rip. So plan was to give loading doses of ranibizumab followed by treat and extend. I gave one injection ranibizumab. Patient comes back after 6 weeks with hardly any response to the drug. Now, seeing no vision gain, I switched the patient directly to brolucizumab. 4 weeks later, there was significant reduction in the fluid levels. BCVA had improved to 6/60. At 8 weeks post brolucizumab, all the subretinal fluid and intraretinal fluid had gone away. So he receives another injection at this point in time with a BCA improvement to 6/24. 6 weeks post brolucizumab, he's all right. He's asked to come back after 4 weeks, but then he comes back at 7 weeks later, where he again has a recurrence. So BCVA had dropped down. At this time, he received his third brolucizumab injection. So this patient has been under my follow-up for the last 3 years. This is the last OCT before the last injection given. His BCVA is down to 6/36, and he has received around 15 brolucizumab injections at a frequency of 3 to 4 monthly, but he's still able to manage all his work. The second patient is a 60-year-old female. She came with decreased vision in her left eye, diagnosed as neovascular AMD, already received 3 monthly ranibizumab and 1 aflibercept. Vision was 6/18 with treatment with no further improvement in the anatomical structures. Last injection was given 3 months back. This is the first time when I saw the patient. As you can see, there's a well-defined membrane complex along with subretinal fluid and SHREM. Injection ranibizumab was given to the patient. I called her after 2 weeks. There was some response. There was some decrease in the subretinal fluid. But at 4 weeks, she seemed to have a recurrence, and vision was 6/18 in all these times. So I shifted the patient to brolucizumab, looking at no response to all previous anti-VEGF agents, including aflibercept. 4 weeks post brolucizumab, all the subretinal fluid goes away, and this is the first time when the patient has 6/9 vision. However, she again has a recurrence. She receives a second injection. So 2 weeks after brolucizumab, vision is back to 6/9. 6 weeks, she has a mild recurrence, and the third injection was given at 7 weeks. Again, this patient has been under my follow-up for the last 3 years. This is the last OCT picture. This was taken 1 month back. She has received around 14 brolucizumab injection over the past 2.5 years. Fortunately for her, the last injection was given in November 23. So she has been more or less disease-free for the past 1 year. She is on a 3 monthly follow-up. And her BCVA is maintained at 6/9. The last patient of this series is a 40-year-old female. She's a working mother. She was diagnosed as pachychoroid with type 1 CNV. Between October 2019 to September of 2021, I had to inject 14 ranibizumab and 2 aflibercept injections, but her BCVA was maintained at 6/9. So this is one of the cases. This is the OCT of the patient showing the CNV and the angiography showing the leakage. So this is September of 20. Yeah, so this is the last time when I saw the patient. Her BCVA was 6/9 and she had a recurrence. This is the time when I switched her to brolucizumab after discussing that she requires very frequent injections, although the injections were actually working. So she receives 1 injection, then I see her again in December 21, she's fine. Jan 22, she is fine. Feb, March, April, May, June, July, and again she has a recurrence in September. So she was disease free after getting so many injections for 1 year after one injection of brolucizumab. This is November of 22. This patient came back in September 22. Her BCVA is 6.6 and she has been disease free for the last 24 months. She's on a 3-monthly follow-up schedule. With this, I'll come to some DME cases. So the first patient is a 60-year-old female, BCVA 6.18 and 6.9 in the right and the left eye. These are the OCT images. The right eye, in May 22, BCVA was 618, CMT was 387 microns. She had history of 3 ranibizumab, 1 aflibercept, and 1 ozurdex in the right eye over the last 1 year. Her HbA1c was 6.7. She received 1 injection of brolucizumab. This is July. BCVA is 618, but the CMT has gone down to 330 microns. This is when I gave her the second injection. She comes back in August, BCVA improves to 6/12, CMT goes down to 276 microns, and she's kept under observation. Now she comes back after a year, her BCVA is 6/12, CMT is down to 287 microns. Again, she's kept under observation. She comes back in December 23, BCVA drops down 1 line, CMT also drops down, and she has developed cataract for which she was operated. Vision again comes back to 6/12. This is April 24, CMT is down to 215 microns, BCVA is 6/12. Meanwhile, the other eye of the patient, which was 6.9 to begin with and a CMT of 300, it kept on deteriorating. The patient was not willing for treatment. I advised an injection in December 23, but she wasn't willing. Finally, she received 1 brolucizumab in April. And these are the latest OCT images of the patient. As you can see in the right eye, there seems to be no disease whatsoever. BCVA is 6/12, CMT of 205 microns, and she has only received 2 brolucizumab injections, the last of which was given in July of 22. The left eye also shows vision improvement, and the CMT is down to 245 microns. The next patient is a 65-year-old lady. She had mild cataract and non-fovea involving DME. BCVA was 6.9, both eyes, good systemic control, and she was kept under observation. Patient lives far away. She came for follow-up after 4 months. She was, and in the meantime, she had a cataract surgery in her left eye, which was performed elsewhere. So this is when the patient came back to me after 4 months. Her vision had dropped down to 6/24. She had received 3 monthly ranibizumab, but there was no improvement in her vision. So the first thing for me to do was an angiogram to look for any form of CME, post-cataract CME, but on doing the angiogram, I realized that there were few leaking microaneurysms which were not responding to anti-VEGFs at all. So the plan was to do focal laser followed by brolucizumab, and this is the OCT of the patient. She's been maintaining well for the past 1 year. BCVA is 6/9. The next case is a 60-year-old male. Now this is a colleague's father. He had DME in the right eye. BCVA was 6/9. This is March of 24. He received first injection in April of 24 when vision dropped down to 6/12. In May, the vision remained same, but the DME decreased, and in June 24, DME decreased further. In August 24, just after 1 injection, the DME seems to have disappeared. Similarly, a 58-year-old female, bilateral DME, poor metabolic control. These are the initial OCT images. She was asked to control her sugar levels and then come back after a month. In between, she went to a different city. She received 3 ranibizumab and 1 aflibercept in each eye. Her HbA1c had come down to 8, but the DME had increased a great amount. So looking at the OCT pictures, I injected ozurdex in both her eyes. 2 months later, the left eye seems to have responded very well, but the right eye did not show that good a response. At 3 months, there was a recurrence in both the eyes. So at this point in time, I gave brolucizumab in both her eyes. This is after 1 month. The right eye again seems not to have responded much. But after 3 months, as you can see, all the fluid has gone away. This is after 6 months of 1 brolucizumab injection, and the patient has now received the second injection in the right eye. The left eye is still under observation. What has been my experience so far? I have used more than 550 vials so far. I've used this drug in all possible indications. This is my first line agent for all approved indications. In my experience, the response in AMD and DME differs markedly. In cases of AMD, I would want to hold till 8 weeks before injecting. And in DME, I would actually wait for 3 months before injecting again and only inject if I can document that there has been a disease recurrence. I have had one case of mild intraocular inflammation encountered yet, which was managed with topical steroid drops, and there was no vision loss. So what has been my crux of 4 years? This is the drug, I guess, which gives us the longest longevity, which leads to fewer injections. It decreases the financial burden to the patient and ultimately leads to increased patient compliance. This is a statement finally. Thank you.
Thank you, Dr. Tiwari.
Thank you, sir.
We go straight to the next talk. Dr. Ajay Arora will speak on micropulse laser principles and his experience in managing chronic CSR, venous occlusion, and DME.
Thank you, sir. And I thank the organizers for the opportunity. I'm talking about subthreshold micropulse laser principles and my experience in managing chronic CSR, venous occlusions, and DME. So what I'll be talking is a basis of micropulse laser and my experience in these conditions. There are other conditions in which we have used subthreshold micropulse laser is ERM with macular edema, post-radiation macular edema. So basically you must understand what micropulse laser is all about. It is not a continuous wave laser. It's a laser which has been split up electronically into small components. So there is an on time and an off time, and it is the off time that matters most. So that is why we can have 5% duty cycle or a 10% duty cycle or a 15% duty cycle. So a sub-threshold continuous wave scanning laser is not equivalent to micropulse laser. In a micropulse laser, there is 100% tissue sparing, while a sub-threshold laser, there could be an obvious damage of the OCT, which can be detected once we, on the OCT as such, but in a micropulse laser, even the OCT damage does not occur. The wavelength to choose is 577 microns. And this shows you the mechanism by which a micropulse laser works. It is actually releasing the heat shock proteins, and these have an anti-angiogenic and tissue restorative factor. The modality of using a micropulse laser has been now shown as a low intensity, high density application, which means when you give the pulses, there is no interpulse or an interspot distance. So they do not overlap, but there is no distance between the two. So this is a low intensity, high density distribution. These are the basic facts about CSR, but because of positive time, just to say that we do not treat acute CSR, you must take care of all the factors like stress, smoking, and antioxidants. So I'll be talking on, and I have actually almost stopped giving apnea to my patients. There are various other agents indicated, but I would continue on antioxidants and treat them with micropulse laser. We now have about 34 patients with a follow-up of 18 months to 7 years in these patients with a mean age of 39 years. We are coming out with a major publication on this, with a pre-MPLT visual acuity of 0.5, post-MPLT visual acuity of 0.72, and a mean NSD of 230 microns with a reduction of 72.3 microns. So I'll show you these cases. So this was a patient who was a laparoscopic surgeon, a 47 years old male, who was diagnosed CSCR in 2015. He has been treated with all modalities of treatment, including a thermal laser. You can see the spot of a thermal laser here. And he came to me and I suggested that we do micropulse laser. After treatment, he asked me, why was I not told about my subthreshold micropulse laser earlier? So this is his picture. I followed him up now for 4 years. There have been 3 episodes of micropulse laser treatment in this patient. So this is pre-micropulse and this is post-micropulse, and he did well. This is an Ophthal resident. He has now finished his post-graduation. And he used to drive down and come to me with his the CSCR. We treated him, managed him well. He was under tremendous amount of stress. So this is the first treatment he received in November 2018, which was followed up with, there was a reduction of neurosensory detachment, as you can see here. He received a second treatment here and then was followed up in February 2019. The fovea was absolutely flat with disappearance of a neurosensory detachment, and he did well. This is a dentist who has been under various forms of treatment with apneuron, transpupillary thermotherapy. He was a smoker. We did his angiography and an octa. We found that his right eye had a pachyneovasculopathy with a neurosensory detachment, which was treated with ILIA. This was then followed up by treatment with micropulse laser in both eyes. So he received micropulse laser and we called him and he came back after about 3 weeks. So just to point out, in all the patients whom we have followed, we find that neurosensory detachment can actually increase after micropulse treatment in first 26 days. So they have been varying periods in these cases, but eventually in about 6 to 8 weeks, this flattens off. So we do not repeat treatment for about 2 to 3 months, and the patients did well. So the take-home message from these cases, I have now a large series of patients that SMP works in cases of chronic CSR. We've had a success rate of almost about 96%. It is not a one-time treatment. It may need to be repeated. For the initial effect to come, it may take 2 to 3 months. The NSD may increase immediately after laser, but gradually it settles down. Please rule out a secondary choroidal neovascular membrane before treating micropulse laser. So this was an army general who had come to me with non-ischemic CRVO. He knew everything about anti-VEGFs and he said, I do not want any anti-VEGF injected in me, and I have now followed him for many years. And we gave him a subthreshold micropulse laser, and this is his sequential pictures over a period of time, and he responded well. We have been managing him since 2015. This was a 23 years old female, non-diabetic, non-hypertensive, possibly an inflammatory branch retinal venous occlusion with a homocysteine of 7.1, and she received 2 Avastin injections for her macular edema with branch vein occlusions. This is the second injection which she received, and then for some reason she said, I am not willing for repeat injection of Avastin. And you can see here a large area of capillary non-perfusion, which we treated with a sectorial micropulse laser of 10% duty cycle. This is a sequential angiograms of this patient. You can see the neovascularization of the disc having become more fibrous with reduced leakage, and this is serial OCT of the same patient. I followed this patient now for almost 9 years. And she has now moved out of India. She's in Ireland now, and she comes for the annual checkup, and she is doing pretty well, maintaining a visual acuity of 6/6 parts. This is a Whitefield octa, and she's done well. This is another patient of BRVO who came to us during COVID times, was not vaccinated, developed a branch retinal venous occlusion, received injection eccentrics, and subsequently we decided to do micropulse laser. For the macula, we did 5% duty cycle. For extra macular area, we did 10% duty cycle. And now I have followed this patient again with OCT and an unfast imaging. And this is his picture. He did receive a small focal laser for the small NB he is developing, but for this large area of capillary non-perfusion, he has been treated with micropulse laser and is doing well. It's been shown by various authors that micropulse laser is as good as modified ETDRS protocol of focal laser being used. So we have treated a few patients with micropulse laser. Obviously, metabolic control is extremely important. And we have done a micropulse laser pan-retinal photocoagulation after taking a due consent that this is not a prescribed treatment for cases of PDR, but these patients have stabilized, and we have followed up sequentially with field charting and shown that the fields do not deteriorate, which would have otherwise happened if we had done a normal PRP. So the question and a take-home message to all of you is, if you do not have the ability to do a micropulse laser, at least refer the patient, especially of chronic CSR, where this ability is available, so that the patient does not ask the question, why I was not told about subthreshold micropulse laser. Thank you very much.
Thank you, Dr. Ajay. Is Dr. Shamik Parful here? Dr. Shamik Parful?
I think the session time is over, so we need to really wrap up the talks quickly.
Yes.
Ajay, can you just briefly tell?
I'm sorry, we cannot ask questions. We are already beyond time. Please start your talk.
Good morning. I would like to thank the organizers for giving me this opportunity. Um, so about the CSR, it is a chorioretinal disease that causes idiopathic serous detachment of retina associated with one or more areas of leakage from the choroid. Is one of the most common phenotypes of pachychoroid spectrum, especially in the Asian populations. Needs multimodal imaging in order to accurately diagnose and distinguish between CSC and other conditions with overlapping clinical conditions. So there has been quite a lot of discussion about the classification of these CSCRs. There has been acute and chronic, which we have been seeing. And then we also have the newer classification put forth by the international expert group, which has classified it into simple and chronic, based on primary, recurrent, resolved, persistent, etc. So these are the risk factors that we all know about, commonly being glucocorticoids, stress, and the other ones including untreated hypertension, use of alcohol, pregnancy, etc. So conventional management, we have conventional investigations like the fundus fluorescein angiography showing ink blot leaks or smokestack leaks, which is the most conventional one. The other one which we have recently come across is with the indocyanine green angiography, which shows hotspots and also shows the vasculature of the choroid. And nowadays it is going more towards the CSCR is being called as a choroidal disease, and we can see on ultra-wide field ICG with the watershed zones of the choroidal vasculature changing and going across the horizontal midline. Then we have the OCT, which shows leakage, which identifies the leakage site and disruption at the leakage site. Morphological analysis of the choroidal vasculature, thickness which can be measured, hyperreflective dots in the SRF, and detecting occult CNV if at all by the presence of double layer sign, etc. Octa also helps us in some way or by detecting choroidal neovascular membranes and the choroidal vascularity index, the vascular density, fractal dimensions, etc. The newer investigations which are there in the pipeline are non-invasive techniques, mainly the flavoprotein fluorescence and multispectral imaging, but these need further evaluation and have not been officially come out in the market. Therapy-wise, we have been using laser photocoagulation. We have had good results with PDT, especially the half-dose PDT, where it has been effectively shown to reduce SRF, choroidal thickness, and vascular hyperpermeability, and has been used in recurrent, atypical, and chronic CSCR. And these trials have convincingly shown that half-dose PDT is a great help. But unfortunately, not all the centers can afford or have these PDT lasers, and we are unable to do it on a routine basis. The other things that we can do is observation, especially if it is a acute CSCR, and we have seen that almost 90% of these are self-limiting and resolve spontaneously. Sir has given an excellent presentation. Arora sir has given an excellent presentation on high density subthreshold micropulse laser. However, most of the literature as of now mentions that it is not superior to half-dose PDT, but then Pacurus trial concluded that can be of use in chronic CSCR where PDT is unavailable. But as sir did mention, we have to repeat the HSML over a period of time. Pharmacotherapy, we have used anti-VEGFs, bevacizumab has been used, and recently aflibercept and brolucizumab have shown good results, but not in all the cases, and we still know that it is an off-label use, and further studies are needed to correlate and confirm the outcomes. Mineralocorticoids and glucocorticoid receptor and antagonists have been shown to be used in these CSCRs. They have been, the rationale is that raised levels of cortisol, which can be taken care of, and the dysregulation of the mineralocorticoid receptor level in CSC patients. So eplerenone was used quite a lot, but the Wiki trial didn't show much of clinical efficacy and showed that it was not superior to placebo. And there have been usage of spironolactone, mifepristone, all have not been as good as many of these other conventional lasers that we have done. The other oral medications which are being used are aspirin, melatonin, antioxidants, H. pylori treatment, beta blockers, ketoconazole, and rifampicin. So as of date, we know acute CSR, we are to
Sir,
look
can
at.
you please conclude because
Yes,
we
sir.
have run out of time.
Yes, sir, we are almost done. We can observe, and if there are, if it doesn't subside over 4 to 6 months, we can proceed with the half-dose PDT. And if it is chronic, then we know the treatment is pretty much what is there. So by concluding, there is still no unanimous consensus about its classification and treatment. Further large-scale and well-structured clinical trials need to be conducted to provide more evidence about clinical efficacy of oral medications. And to date, half-dose PDT is considered by most of the authors the gold standard.
Thank you very much. Dr. Tinku Bali,
Hello.
please. Try to finish in 5
Yes,
minutes,
sir.
please.
Please put up my slides. Sorry for encroaching on the next session. So I'll be talking on the management of epiretinal membranes. Now, epiretinal membrane is a fibrous proliferation on the retinal surface, which is typically idiopathic, but can also be secondary to retinal vascular diseases, uveitis, trauma, retinal detachment, or lasers. So this is seen as a highly reflective membrane on the retinal surface. With the retina gets a corrugated appearance, there is loss of the foveal contour. The retina may be thickened, there may even be frank edema. You see vascular distortion, retinal folds. In severe cases, there could be foveal ectopia and even a macular pseudohole. So epiretinal membrane can have a wide spectrum of presentation. It can just be a benign asymptomatic condition to debilitating metamorphopsia and central visual loss. Now, visual acuity and the patient's symptoms are the most important factors to consider in deciding whether to recommend vitrectomy in an eye with an epiretinal membrane. So there may be patients who have a thick membrane, but if they're maintaining good vision, you can leave those patients alone. And the OCT picture is important to prognosticate. So if you see this ellipsoid zone is intact, those are the patients who will get a favorable outcome after surgery. So these membranes can either be globally adherent or loosely adherent. Now, one thing to tell the patients is that the vision may not improve immediately after surgery. The improvement goes on for the next 5-6 months, and if the duration of the symptoms has been long, then the visual outcomes are worse. The surgery standard after doing a vitrectomy, PVD is induced, and then dyes are used to stain this. So we can do an ERM peeling followed by a subsequent ILM peeling, and the pinch and peel technique using the ILM forceps is used. Now there are two dyes which help with this. One is the trypan blue and one is brilliant blue. This selectively stains the ILM and this stains the ERM. The trypan blue that we retina surgeons use is of a higher concentration than the ones used by the cataract surgeons. So ILM peeling can be done in some selected cases to reduce the recurrence rates, especially patients who have a lot of stria. So in those ILM peeling is done and it guarantees complete removal of the epiretinal membrane. So I'll just quickly show you some situations. This was a patient post branch retinal vein occlusion. You see this ERM at the macula. So one drop of dye is enough to stain this membrane. You can see it otherwise also, and then you get, once you stain it, you can see this nice edge of the membrane which is then peeled off. Now the important thing to consider is that it should be peeled gently because these membranes may be attached to the disc, and if you tug at it, you can have bleeders, severe bleeding at the disc. So it should be done very gently, going all around the disc. Sometimes when sometimes you can just stain the internal limiting membrane. This is called negative staining of the epiretinal membrane. Here you see that the epiretinal membrane is not stained. It's just the ILM which is stained. And then you can pull it off. Again, a case of BRVO, and very gentle dissection is done at the disc. Now, post-uveitis epiretinal membranes may have a very firm attachment to the retina. And every epiretinal membrane behaves a bit differently. So you see this is a more elastic kind of an epiretinal membrane. You have to really pull and tug to get it off the macula, as you see here. It's very elastic, not like the other membranes that I showed you before. I'll just skip over this. Now, epiretinal membranes which are difficult to peel can be removed along with the internal limiting membrane. So here I'm trying to get an edge of the epiretinal membrane, but this patient has a macular hole and I'm not very clear where the membrane is ending. So we can get a grasp of the internal limiting membrane and pull it off. And then once the ILM comes off, the epiretinal membrane automatically comes off along with the ILM. So this is a very good technique when you're not very sure where, or if it's a very adherent epiretinal membrane, you can just peel the ILM from a different area and the ERM comes off along with it. Now in diabetic membranes, you can use your cutter itself. So here's a membrane at the macula. You can use the cutter. There are 2 pegs of attachments here, and then you have to go find an area where it is not attached to the retina. You can dissect in between and you get these 2 pegs now. And very carefully using the cutter itself, you can get it off. But you have again to be careful that you don't pull at this area where it is attached to the main vessel. And this is how it is removed easily. So this is a case of post-trauma epiretinal membrane. This patient had a vitreous hemorrhage. And once we remove the hemorrhage, you see this big epiretinal membrane, a very thick membrane at the macula, which cannot be pulled off with the forceps. So here again, you need to use the cutter to dissect this membrane. Similar to the diabetic membrane, you get an area where it is not adherent to the retina, and then you cut it and remove it with your cutter. So in patients of retinal detachments with a PVR, there is generally an epiretinal membrane present at the disc, and unless this membrane is removed, the retina will not settle. So in PVR cases, you should go to the disc, look around there, you'll find a thick membrane. And once this membrane comes off, the retina falls back, and then it's easier to do the surgery. So see here, this very thick membrane in a child. I'll just skip this. So this is a case, my last case, this is a case of a vascularized epiretinal membrane. Patient had a branch retinal vein occlusion. You see how vascular it is. So the patient laser was done, PRP laser was done, and the vascularity did come down after the laser. The patient was also given an anti-VEGF injection, and you see it has become avascular. This is the OCT, pre-op OCT. Now in this, I was anticipating a very difficult surgery, but to my surprise, the membrane came off right when I induced the PVD itself. So here I'm trying to induce the PVD, and while inducing the PVD, that whole thick membrane complex came off very easily, very simply. So the surgery was a very short and sweet surgery. There you see the membrane came off. So this is the pre-op photo of the patient. This is a post-op picture. So as I said, these membranes sometimes the retina may take time to resolve. There's still some amount of subretinal fluid present. I'll just skip the other videos now. So thank you so much, just to show you a few scenarios and how to manage epiretinal.
Thank you, Dr. Bali. And I'd like to thank all the speakers. I'm sorry we over-delayed it because of some of the candidates were missing. Speakers was missing in the beginning. Anyhow, thanks very much for your cooperation.